Good afternoon, and welcome to today's live-streamed virtual global congressional briefing entitled Better Understanding Thyroid Eye Disease, Physician, Patient, and Caregiver Perspectives with the discussion on women's vision health. I am James Jerkowski, Executive Director of the Alliance for Eye and Vision Research, or AEVR, a 501c3 foundation that educates about the value of vision research and serves as the privately funded Friends of the National Eye Institute, or NEI, within the National Institutes of Health. This briefing is held under the auspices of AEVR's research-saving site, Restoring Vision Initiative, and in conjunction with AEVR member organizations Research to Prevent Blindness, Society for Women's Health Research, Association for Research in Vision and Ophthalmology, or ARVO, which is providing today's live streaming support, and Novartis and Horizon Therapeutics, which are providing today's event management support. Since ARVO is providing today's streaming, I'd like to ask ARVO's Laura Lanford to briefly discuss how participants get the most out of today's briefing. Laura?
Thank you, Jim. In advance of today's program, I would like to go over a few housekeeping items. This briefing is set up as a Zoom webinar and not a Zoom meeting, which means that only our speakers can turn on their video cameras and communicate verbally to the group. For participants, all communications should be directed to the speakers via the Q&A and chat features. Please use the Q&A box at the bottom of the Zoom screen in order to type your questions to the speakers. Please only use the chat box for other communications, such as letting us know of any technical issues or providing other comments that are not content-related questions. This helps our moderator better organize the incoming questions since they will all come through the Q&A box. Time permitting, all questions will be addressed during the Q&A portion of the briefing after the presentation at the end of the program. As a reminder, a video recording of the briefing will be available on the ARVO YouTube channel within 2 business days of the live event. A link to the event page with the video recording will be sent in a follow-up email. I will now turn it back to Jim. I hope you enjoy the program.
Thanks, Laura. Today's briefing will begin with a physician's perspective from Kimberly Cockrum, MD, FACS, who is a board-certified ophthalmologist with fellowship training in both neuro-ophthalmology and oculofacial plastic and reconstructive surgery. Dr. Cockrum is a decorated veteran who trained and was on faculty at Walter Reed Army Medical Center. She has been in private practice in California since 2004 and was appointed adjunct clinical associate professor in 2006. Just recently, she has begun to split her time between the Central Valley Eye Medical Group in Stockton, Modesto, and Manteca, and the Senta Clinic in San Diego. Dr. Cockrum has a long-standing clinical and research interest in thyroid eye disease and is currently involved in numerous multi-center clinical trials. We'll then hear from Ron and Vicki Barella from Washington State. Ron, a TED patient, is a retired law enforcement and commissioned officer in the United States Coast Guard Reserve, and his wife Vicki, a veteran registered nurse, has been supporting Ron in the caregiver role. Their story sheds light on the impact of TED, not only for patients, but for those around them as well. Finally, we'll have a discussion about women's vision health, moderated by Kira Baldonado, the Vice President of Public Health and Policy at Prevent Blindness, and featuring Catherine Godburn-Schubert, the President and CEO of the Society for Women's Health Research. I have been fortunate to have served in 2020 and 2021 on the Society's dedicated activities for women's eye health along with Kira, and we look forward to hearing more about the educational deliverables emerging from those activities. So now I'd like to turn it over to Dr. Cockrum for her comments.
Hi, I want to thank everyone who participated in organizing this terrific program. It's very exciting to talk about thyroid eye disease to a wider population. So as was noted, I'm in 2 locations now. COVID has really done quite a destructive path across healthcare in the United States. We've lost 500,000 healthcare providers, nurses, doctors, and other ancillary staff who've either gotten long COVID, who've retired or left the sector due to PTSD and other factors. So I was actually recruited down to San Diego because they had lost a number of neuro-ophthalmologists and were in need of care. So let's move it along and we'll go to the next slide. So what are my objectives today? So I'd like to provide an overview of thyroid eye disease. This has been a passion of mine for many years, taking care of patients with a wide variety of autoimmune diseases, but specifically with a clinical and research interest in thyroid eye disease. So let's review the clinical signs and symptoms that the patients experience. And then I want to help you understand the physical and the emotional burden on these poor patients who oftentimes see 6, 8, 10 physicians before their diagnosis is confirmed and that they're put on the path of having a therapeutic intervention. Also, I want to just talk about the treatments and what is the standard of care in view of FDA approval of a new biologic. Next slide, please. So what is an autoimmune disease? Well, autoimmune diseases are conditions where your body mistakenly attacks itself. So normally the immune system can tell the difference between you and something bad. But in the case of autoimmune disease, the immune system makes a mistake. It identifies your body. It could be any organ structure. In this case, it has to do with the eyes and the thyroid, but it releases proteins called autoantibodies, and these attack healthy cells. So it's a mistake. So an autoimmune disease is a mistake where we're attacking ourselves. So the most common autoimmune diseases are type 1 diabetes, lupus, Graves' disease, multiple sclerosis, rheumatoid arthritis, and thyroid eye disease falls into this category. Next slide, please. So what is thyroid eye disease? Well, it's commonly referred to as TED because it's a mouthful to say thyroid eye disease all the time. So TED is a debilitating, progressive, and in some patients, vision-threatening autoimmune disease. So the body is attacking the tissues behind the eyeball. And you can see here that there's an expansion of the muscles, the fat, and it results in bulging of the eye forward, which is called in medical terms proptosis. The patients become inflamed, swollen, they're in pain, and you can see there's a stare to the eye along with that bulging. Next slide, please. So who gets thyroid eye disease? Well, up to 50% of patients with Graves' disease, which is the most common form of hyperthyroidism, may develop TED. Women are much more likely to get this disorder. And I would say in my practice, it's at least an 8-to-1 ratio. There's been a wide variety of theories why women are more affected, but in general, women are more affected by autoimmune diseases. Men, unfortunately, if they do get thyroid eye disease, often have an elevated risk for more severe disease, so visual loss due to optic nerve compression or corneal compromise. It can affect a person of any age, but there are 2 peaks, one in the 40s, one in the 60s. And smoking, so tobacco smoking, whether it be vaping or classic tobacco, increases the risk of TED by 8-fold. And it not only increases the risk of disease, but severity of disease, and also patients don't typically respond as well to therapeutic interventions. So steroids are not as effective, orbital radiation is not as effective, and even patients undergoing surgery can end up having a flare of the disorder after surgery if they're a smoker. The newly FDA-approved IGF-1 receptor inhibitor does work in patients whether they're smokers or not in a unique fashion. Next slide, please. So what's the look of thyroid? So all of these patients have thyroid eye disease. And as you can see, there's a very heterogeneous presentation. So patients typically start with red, irritated eyes that then become swollen. So they may notice that their eyelids look more swollen in the morning, and then it progresses that the eyelids look more swollen the whole day. Then usually the eyes start to bulge a bit. A stares, so you can see the upper eyelid is too wide open, so that's called eyelid retraction, and it gives kind of that thyroid look. Along with this change in the position of the eye and the inflammation of the eye, patients then start complaining about light sensitivity, eye grittiness, dryness, and even pain. So the pain is sort of like a dental pain, like a vague ache, but it can progress to really significant pain where patients are taking NSAIDs and other therapeutics to try to make it through the day. The eyelid retraction, again, you can see in the top left, the patient is staring. So the white of the eye shows that eyelid retraction causes the patients in some cases to not be able to close their eyes at night. So they wake up with even more pain because they've had exposure while they were sleeping. It can result in double vision because the muscles are expanded and the function of the muscles change so that they can't track. They might be in, they might be out, might be up or down. So each patient can be different. The double vision may only be there in the morning or can be there throughout the day and really disrupt the ability to do tasks of daily living. And then they can have blurred vision. The blurred vision can be because the surface of the eye is dry. It can be because the patient has started to have optic compression, optic nerve compression. So the muscles get big behind the eye. Or it can be that the cornea is starting to break down. As I said, if you can't close your eye at night, then you're going to have problems with the cornea being smooth. The cornea is like the windshield of a car. So the cornea needs to be clear to be able to see out. Next slide, please. And click next slide. Perfect. So visual loss is, of course, the most concerning. So we talked about you can have exposure of the surface of the eye, the cornea. You can have compression of the optic nerve by the enlarged muscles and the expanded fat. So let's look at this patient. So the patient has bilateral bulging, known as proptosis. The left eye is worse than the right, which is typical. Oftentimes patients have bilateral disease, but one eye starts out worse and progresses faster than the other eye. So not unusual presentation. And you can see the white of the eye, especially in the left eye, is very red. So that's called conjunctival injection. Nothing's been done between the top picture and the central picture. The patient is being observed and there's been no intervention. And you can see the disease, if there's no intervention, often progresses to even worse looks and more pain and more exposure. So in the middle one, the patient now has fluid under the eyelids, under the conjunctival surface. We call that chemosis. And you can see now that the eye is displaced. So the patient is trying to look straight ahead, but they're not looking straight ahead. The eye is looking up. And that's because the muscles behind the eyeball have changed. And you can see on the picture on the right, that's a formal visual field called a Humphrey Visual Field Test. And this is something that's performed on patients routinely when their evaluation to see whether their optic nerve is impaired. And that area that's grayed out, that's not normal. That's the area the patient can't see. And then the bottom slide is the patient shown after a therapeutic intervention. So in this case, this is a patient who received an IGF-1 receptor inhibitor, and it allowed the patient to have the eyeball restored to a much more normal position. You can see the redness is improved, the swelling is improved, the position of the eyeball, so the double vision is improved, and the visual field is now normalized. So therapy is extremely important, and therapeutic interventions at the right time to avoid a permanent catastrophic visual loss is very, very crucial. Next slide, please. So thyroid eye disease has a broad impact, both emotionally and physically. If you have something, let's say a psoriasis plaque on your arm, you can wear a long sleeve shirt. If you have thyroid eye disease, you can wear sunglasses, but it looks a little funny to be wearing sunglasses everywhere. But it's very hard because we communicate with our eyes. When we talk to someone, we look them in their eye. Whether we have a mask on or not, whether we're on a Zoom call or not. So the eyes are very important to our ability to communicate with other people. And so having thyroid eye disease not only impacts how the patient sees, but also how they look and feel. They just don't feel comfortable communicating with others. In addition, they can't perform tasks of daily living. Even patients with mild thyroid eye disease can have really significant tearing, irritation, light sensitivity that makes it difficult to drive, to work on a computer, to look at their cell phone, to read. And then, of course, it impacts their hobbies. So patients really end up being very depressed, anxious, and socially isolated. I have a lot of patients say, I just don't feel comfortable talking to my partner. I don't feel comfortable at work doing presentations. My grandchildren run because my eyes look scary, and they actually are scared of how I look. So it's really impactful from an emotional standpoint, both for what's going on at home and professionally. Next slide. So what are the current treatment options for these patients? Well, 20 or 30 years ago, there was many more patients were just observed. So when I was in fellowship, it was very common that we would tell the patient there's a curve of activity. So basically, you're going to have to get worse before you get better. And you can put some eye drops in your eyes, but there's not a whole lot we're going to do. We're going to wait until you are no longer red and puffy. And then what we're going to do is we're going to go in and take away bone, which is what a decompression is, to try to get your eyeball to be back where it should be. That's evolved so that I think many more doctors talk to patients about the local measures in a more complicated way. So we talk to them about using artificial tears without preservatives because the preserved kind can be irritating. Talk to them about ways to protect their eye at nighttime when they're sleeping. So ointments, taping of the eyelid, eye masks. During the day, use of sunglasses or tinted lenses can be very helpful with the light sensitivity. And then some supplementation, if your vitamin D or your selenium is low, supplementation can be helpful in terms of moderating the inflammation. But most patients, once it starts to impact daily tasks, whether it's being able to work on their phone or their computer or drive, clinicians then talk to them about different therapeutic options. So when you're hot or active, where you're red and puffy, you have two different options. You can go after the inflammation with either steroids or radiation, or you can use a targeted biologic. A targeted biologic called teprotumumab was FDA approved back in January of 2020. Prior to that, we really just had the corticosteroids, the orbital radiation, and some off-label use of other monoclonal antibodies. The steroids can be used either as an injection behind the eye, intravenous over the course of multiple weeks, or oral. The problem with corticosteroids is there are a lot of side effects. So patients have weight gain, acne, facial expansion, so their face gets very large, but they're already anxious, and you put an anxious person who's hyperthyroid on a steroid, and it just makes them even more anxious. They can have panic attacks, can have GI symptoms, so a lot of side effects. Orbital radiation is effective in select patients. It works best in patients who just recently had the inflammation occur and that are actively inflamed at that time. Since January of 2020, as I mentioned, there's a new option that is FDA approved, so you can get it authorized through insurance companies. It's an IGF-1 receptor inhibitor, which means that it's a very targeted medicine. So it targets part of the components that make the eye inflamed. So it stops the cell-to-cell signaling and stops the autoimmune process. It's also unique in the sense that none of these other therapies do what it does. It makes the muscles that are big go back to a more normal size. It takes the fat that's expanded and makes it go back to a normal size. Surgery is still an option. Certainly if patients are in a more quiet phase, they can undergo an orbital decompression. On occasion, we have to do orbital decompressions semi-emergently for patients with optic nerve compression. Patients can have double vision surgery, which is referred to as strabismus surgery. And then that stare, that open eye, that too open eye that's causing irritation, we can do eyelid surgery to relax those muscles. So prior to January of 2020, we really had to break this into two kind of populations. So you had the active patients and you had the inactive patients. So the active patients, you could do these anti-inflammatory treatments. And your chronic patients, where they're not active, you could do surgery. But there was nothing that kind of crossed over. With the targeted biologic, it actually treats patients whether they're active or inactive. It's not sensitive to the onset of the disease like orbital radiation. So you have a wider window during which you can use this biologic to help patients achieve their goal. And of course, the goal is to get them comfortable and get their visual function back so that they're able to go back to work, have normal social interactions. So it's been really exciting to see the evolution. There are a number of IGF-1 receptor inhibitors that are being developed. Clinical trials are going to be held. So there'll be more competition on the market. But again, at this point, there's just the one approved one. Next slide, please. So why do we want to identify thyroid eye disease early? Well, again, decades ago, we just watched patients get worse and worse and worse and become, disabled before we just broke the bone to try to put the eye back together. We've definitely really evolved. So when patients are seeing their primary care or they're seeing their IOD, their optometrist, it's really important that these gatekeepers are aware of thyroid eye disease, are aware of the early signs of thyroid eye disease and symptoms, so that the patients can be referred to specialists for therapeutic interventions. So the initial assessment, whether it's by primary care, endocrinology, or when they're getting their glasses from their optometrist, is to ask the patient, are you in pain? And is that pain impacting your ability to work on computers, to work to work on a phone, to do whatever you need to do to get through your day at work? Second, are you having any visual changes? If you don't ask, patients sometimes don't provide that they're seeing blurry or they're seeing double. So asking patients the correct questions is super important. Has there been a change in your appearance? Looking at somebody's old driver's license, so you can easily see that there's been a change in the eyes, that they used to have much more inset eyes, now they're bulging. And then most importantly, what's the impact on the quality of life? We no longer need to observe patients who are having issues at work or having issues at home or both. We really want to refer those patients on to a subspecialist who can assess them fully. Who are the subspecialists who take care of thyroid eye disease? Well, it's a variety of people. So it could be an oculoplastic surgeon who has an interest in taking care of patients with orbital disease. So the orbit is the box that holds the eyeball, and that's where the fat and the muscles expand. It could be to a neuro-ophthalmologist who cares for patients with double vision or decreased vision. It could be to a strabismus specialist who cares for patients with double vision. Any of these subspecialists will be able to give the patient a comprehensive evaluation and make sure that they detect any defects in visual function very early on and allow intervention. So going to any of those subspecialists, the patient is going to have an inflammation assessment. So they're actually going to be scored. There's a clinical activity score where redness gets you a point, swelling gets you a point. So we're going to assess them for inflammation and score them. Then the patient's going to have measurements, going to have pictures performed. The bulging is called proptosis, and we have different ways to measure that using instrumentation and also the imaging. The eyelid retraction is going to be quantified, but most important, the visual function is going to be carefully evaluated. So we're going to check vision at near, vision at far, color vision, contrast sensitivity, so the ability to detect early changes in visual dysfunction. But then also we're going to do the visual field testing that you saw in that prior patient to detect any changes. And now we have something called an OCT. So it's basically a laser interferometer that projects to the back of the eye and is able to quantify the layers of the retina. So it tells us early on, is there impact to the optic nerve function? That's the ganglion cells. Is there impact to the retina themselves? And then finally, we're going to order an imaging study. And it could be a CT scan or an MRI. And what that's going to do is give us a picture of what's going on in the orbit, the area behind the eyeball. How big are the muscles? How expanded is the volume? Does the patient look at risk for optic neuropathy? And then compare that to the other vision testing that we've done. Patients then can be, you can figure out what's the next step. Do you place the patient on a steroid? Do you talk to them about the IGF-1 receptor inhibitor? What's the next best step for the patient? But communication and early identification is super important. Next slide, please. Are there any questions?
Dr. Cockrum, I have one that came through earlier, and you addressed it to a certain extent towards the end, and that is, I did not hear Dr. Cockrum mention an endocrinologist in the specialist that she described. Could you explain where that individual may fit into this continuum? And then it's a compound question. The second part is there now a better handoff between not only the general practitioner and specialists to the next step for care? Is there more talking amongst these individuals to ensure that a patient gets to the proper care more quickly?
So endocrinologists are crucial in the care of patients with Graves' disease and thyroid eye disease. And endocrinologists often pair with eye professionals, whether that be an optometrist, an ophthalmologist, or a subspecialist, as I was describing. The problem is that, especially during the COVID time, both primary care offices and endocrinology offices were closed temporarily. We lost a lot of subspecialists. I know up in the Central Valley, it's extremely difficult for me to get most of my patients to an endocrinologist because there are so few, and because my payer mix there limits patients' access. So ideally, absolutely, an endocrinologist is involved in the care of the patients. But realistically, in rural California, Central Valley, California, that is not always an option. And then as far as getting patients seen and triaged correctly, that's been a huge challenge because, again, over the last 2 years almost now, patients haven't been able to get, a lot of times they would see their optometrist for new glasses every year, and that was a chance for the optometrist to chat with them and to see that there's something new changed. But patients, either the office is closed or the patients didn't feel comfortable going out. And so I'm seeing a lot of neglected, both thyroid eye disease and neglected other problems where patients now have permanently lost their vision because either they had no access or they were scared of the access. So really hard last couple of years.
Thank you for those insights. And I have one more question here that came through, and that is, even with the new treatments, are you seeing a reduction in the need for therapeutic plastic surgery procedures to undo some of the damage that's been created by thyroid eye disease? In other words, has there been a reduction yet in the need for these kinds of after the fact kind of corrective surgeries, or is there just not enough of a penetration of the treatments yet?
So in my own practice and in discussion with many of my colleagues, there's been a dramatic improvement in the patient's outcomes with the new biologic. And so these patients are not needing decompressions. They're not needing surgery at all. So I think that it's really exciting that we have a new option. In orbital disease, it's thyroid eye disease is an orphan disease, which means it's pretty prevalent in my practice, but it's not enough people that it really got much attention for a very, very long time. And so I'm just super excited that we have this new therapeutic option and it's also spurred a number of companies to look at monoclonal antibodies and to get interested in orbital disease and how we can impact these patients' lives.
Thank you, Dr. Cockrum, and thank you for what you do to treat patients as well as to improve their quality of life. And on that note, I'd like to thank again Dr. Cockrum for her formal comments and ask Ron and Vicki to put on their video and their sound. Great, welcome Ron and Vicki.
Hello.
Thank you for your time this morning. I know you're out in Washington State. And again, you've been listening to Dr. Cockrum. And so we've been talking a lot about quality of life. So Ron, can you tell us when you first started getting symptoms and how it changed your life?
Yes, incidentally, doctor, it's reliving what you were saying. It just put us all through.
I felt like we know you, or you know us. It's such a typical story.
I was in law enforcement for 33 years and simultaneously was a Coast Guard officer in reserves. And I had, back for about 5 months or so prior to December of '92, I started having tearing, the pain, the dizziness and such. And ultimately one day when I was getting ready to go to work in uniform as a police officer, I looked in the mirror and my eyes, one was completely to the left as far as it could go and the other was up and diagonally. And I was dizzy and had all of the common symptoms that you so well explained, and as well as pain and such. Went to a local hospital the next day, was lucky to find an endocrinologist who got me started with steroids, ultimately to radiation, wearing eye patches, and all of those things. And ultimately, I ended up having all of the surgeries in both eyes that one could have at that time. And looking at your slide, basically, they're still pretty much the same. I've had all of them. The situations were dealt with. It took about 2 years to go through my full regimen. Parts were compressed because the surgical ophthalmologist, when he looked at me, said that my optic nerves were being so compressed that he did not want to wait the X number of months for it to stabilize. Within days, I was being operated on. And ultimately, my visual concerns were dealt with. I've got about 85% of the way I was before it all started. Things will remain, and this is about as good as I can get, but I was able, it was fixed enough that I could complete until retirement my law enforcement and my military careers, for which I'm most thankful.
Great, Ron. And of course, we all thank you for that service. Vicki, what was it like to see Ron, who I know was an incredibly vibrant individual and active, to go through this process? And what were your feelings along the way?
Well, we had just newly been married. We'd been married just a couple of months when Ron first exhibited all these symptoms. And it was very tough watching somebody who I had known for several years leading up to our marriage as a very in control, independent, strong person. All of a sudden, he can't drive. He's making messes all over the house because of double vision. And he didn't want to go out and do anything. So it was a huge adjustment. And it was terrible watching somebody you love very much go through all of that. Losing parts of his job, parts of who he was, and not knowing exactly what was going to, how that was going to progress. I think in some ways, I was a little bit luckier than a lot of caregivers being a nurse. I could look at things from that standpoint a little bit, but it was tough watching him.
So, Ron and Vicki, I've spoken to a patient in past briefings who sort of ended her story by talking about how you have to be your own best advocate in this process. Could you talk a little bit, and Vicki, you kind of alluded to this from your background as a nurse. What was your experience in dealing with the medical community, getting care on a rapid basis, getting diagnosed and care on a rapid basis? And did you have to become your own best advocate in that regard? Either one of you can, or both respond to that.
Okay. We're laughing because Ron's the kind of person that if a doctor told him to go stand on his head and it would go away, he'd try it. I ask every question. I want to know everything that's going on. I want to be very, very involved. We have a totally different way of dealing with the medical community. And I see Dr. Cochran laughing.
And both of us being controlling types of people, there were times that we had some interesting conversations, but I had to learn to let go of my desire to control because it wasn't going to happen. I learned very quickly to rely on Vicki for everything from periods of time when I did not have any vision, recovering from surgeries or what have you. Vicki had to teach me how to feed myself, to lead me up and down stairs through halls and such. And I just had to give up a lot of
And-
self-reliance.
But getting through the medical aspect of this, I think Ron relied on me for that also, because I am the one that was more asking the questions and pushing for answers and wanting to know the best, surgeon in the area and all. So people that don't have an advocate to do that, I think do learn fairly quickly to ask and push and learn.
And so one question, Dr. Cochran spoke a little bit about the newly approved treatment, but Ron, I take it that when you were experiencing this, that there was not that treatment available. Could you tell us how many surgeries you had and what type of surgeries they are? Because I think it gives everybody a perspective on, what life was like without these new treatments.
Oh my goodness. I've had radiation to the eyes. I've had the orbital reduction. I've had the strabismus surgeries, the eyelid reconstructions repeatedly. And I still have double vision. I always will. But I've learned to deal with it. I've learned I cannot drive all the time when I want to. Sometimes I can, sometimes I cannot. And therefore, Vicky steps in, drives in. But surgery-wise,
Everyone that Dr. Cochran
yes,
described, Ron had.
it's been a shopping list, and we've done them all in both eyes. And at this point, I am where I'm going to be. It would have been nice. I would have loved to have had the new medical option, but it just was not available.
Yes. In fact, Ron, as you were talking about the procedures you've had, I took Dr. Cochran's slide and was actually checking off the various procedures that she had described there. Okay, so we're going to wrap this up. And Ron and Vicky, again, thank you for your time and your story. But I just, one of the things that I wanted to add is that my organization did a survey back in 2014 of Americans across all racial and ethnic groups, asking them, what's one of the worst things that could happen to you? And loss of vision came to the top of the list. I think that you're a great example of, the kind of fear people have about vision loss. Could you just describe a little bit about, your fears and your hopes and dreams throughout this process?
Well, initially, what I was being told was that I could end up either being totally blind or having minimal vision. And the way I appeared to other people, I scared a fair amount of kids and so forth. And socially, psychologically, it was difficult, not just for my wife, but for my coworkers who looked at me and wondered and pondered. There was a lot of discussion going on, some of which I did not hear, fortunately. Other parts I heard and was able to talk a little bit, but it has a tremendous impact on a person's self-confidence. And so now I've learned to balance between what I can do and be satisfied with it, and what I cannot do and say, well, it's just the way it is.
And Vicky, any thoughts in that regard?
Well, I think you are the fear of what is going to happen. Am I going to have to totally change what you think life is going to be like? Is my husband going to be blind? And how will that affect our life? What will we do? But thankfully, we had good surgeons. Everything went as well as it could during that phase. And my biggest thing, I think, was I was just so grateful that even though it was a serious problem, it affected every aspect of our social and working life for a while, it was not a death sentence. And so I thought, okay, we can live with whatever as long as I could keep him around. And we've actually, our normal now has just sort of incorporated my driving, all the other things that you adjust. We walk into any theater, any lecture, anything, and automatically go to the right because Ron has to look to the left to see single vision. So you just adapt to all of that, and we travel, we have fun, we live a really good life. It was scary in the beginning. It's a lot better now.
Well, Ron and Vicki, you're an inspiration to us all. I have so enjoyed our preliminary chats before today's broadcast. You keep hanging on and you keep doing what you do because you do it very well. So we'll thank you very much and move on to the next portion of our briefing. Dr. Cochran, thank you very much. If you all want to mute your cameras and your sound, we'll now move. Thank you very much, Ron, Vicki.
Thank you.
Now we'll move on to Kira and to the next portion of the program. Kira?
Thank you, Jim. And Ron and Vicki, thank you for sharing your experience with thyroid eye disease, and Dr. Cochran for that overview. I'd also like to thank those of you in the audience for tuning in today on this important topic of vision health with a focus on thyroid eye disease and a look at how vision issues impact women specifically. I'm Kira Baldonado, Vice President of Public Health and Policy at Prevent Blindness, which is an organization founded in 1908 with a mission to prevent blindness and preserve sight. We're working to ensure that vision, and especially the patient voice, is integrated more broadly into health, public health, and community programs. Joining me today is Catherine Godburn-Schubert, President and CEO of the Society for Women's Health Research, or SWHR. Catherine, thanks for being here today. And for the benefit of our audience, can you take a moment to describe the Society for Women's Health Research and what you're doing as an organization to accomplish? Tell us about your mission.
Sure. Thanks, Kira. So SWHR has been around a little less time than Prevent Blindness. We were founded in 1990, and we are known as the thought leader in promoting biological sex differences in disease, the research on how men and women are different, and to improving women's health through science, policy, and education. And so we're really looking at conditions that might specifically impact women or differently or disproportionately impact women.
Well, I certainly appreciate that work, that's for sure. So why a spotlight on vision health for the organization?
Yeah, so as we've seen, the impact of vision impairment, it's one of the most common causes of disability in the US. The number of blind or visually impaired Americans is projected to double by 2050. Women in particular are disproportionately affected by both common and rare eye diseases, such as thyroid eye disease. And in addition to that, eye conditions can present differently for women than men and differently across the lifespan. So we're really looking at some pretty significant differences between men and women here. And then for many of those diseases, just quite frankly, we know very little about what causes them. Treatments in many diseases or conditions are still limited. And so it's really important to think about this holistically.
Excellent. Well, let's dig into that a little bit. So what is the burden of eye disease on women really kind of across that lifespan? Where do we see variations in disease prevalence and issues for women?
Yeah, thank you. So we're looking at a really disproportionate share being women who have eye diseases or conditions. So TED in particular is about 5 to 6 times more common in women than men. It also can be linked to other thyroid diseases, as we saw from Dr. Cochran's presentation, that are also just more prevalent in women broadly. Dr. Cochran did note that men do have an increased risk of TED in older ages. So I think right away we can see that there are differences there between men and women. Other conditions that women are disproportionately affected in terms of eye health include age-related macular degeneration, dry eye disease, and glaucoma. And it's really important to note that vision impairment places a substantial burden on caregivers. So we just heard Vicky's story and her experience with Ron, and thank you both for sharing that. For caregivers, it can be up to 94 hours per week, depending on the severity of vision loss. So there is really a burden there on women, both as patients, but also as caregivers. So, it's really a significant impact from those two perspectives.
Yeah, there's a lot to consider there, whether you're a young woman or one that's aged. There's a lot of different vision issues that can impact you along the way, as well as the caregiver role. So thanks for pointing that out. So tell me a little bit about the work that SWHR has taken to shed some light on vision issues specifically.
Sure. So last year, we convened an expert working group that included clinicians, researchers, and patient advocates to review the current state of science regarding sex and gender disparities in women's eye health. That group worked to identify knowledge gaps, unmet needs. We really wanted to better explore ways to advance the research, improve patient care, and raise awareness of these key issues. We're really thinking again in a holistic way about vision and eye health as it relates to broader health issues for women in particular. And over the course of the next several months following that convening, that working group identified key issues in women's vision health across the lifespan that needed to be addressed. So we have also, in conjunction or as a result of that work, we developed a fact sheet on women's eye health to help explain the challenges and the potential solutions to some of these issues. Just in October, we had a paper published in the Biology of Sex Differences journal, which came out of that roundtable as well. It's called The Roles of Sex and Gender in Women's Eye Health Disparities in the United States. It's published online, it's open access. I think it really identifies a lot of these issues. And then finally, we are developing right now a patient and caregiver toolkit that it's looking to empower both patients and caregivers in navigating their care. So again, every word of Ron and Vicky's story, I think really resonates. And we are hoping that that toolkit will be helpful in terms of helping to empower people to better understand, ask the right questions, learn more about what they're experiencing.
It's been a pleasure to be a part of that work, and I just want to highlight the diversity of stakeholders that you've brought together. It's not just the vision world, but you're really bringing together many different professions, many different voices in that work, and that's just really critical to making sure that we have solutions that work for everyone. So for those of us in our audience, what can they do to work towards improving women's eye health in the real world?
Yeah, so I think there's sort of a multifaceted approach here and several steps that we can take, both learning from that working group, but also in terms of the subsequent work that was done. Number one being the expansion of the research framework that really should be looking more toward a population health approach. And that includes that role of sex as a biological variable in ongoing and new research. So that's really key here. We also think that improving access to telehealth will be important. So, telehealth has really made eye health appointments more convenient for many people, especially women who may not have the time to visit, the doctor due to factors like household responsibilities, transportation barriers, et cetera. We really want to improve provider and patient education. So, increased clinical exposure around eye health for non-ophthalmologists, the specialists, really to be able to understand that vision, again, is a broad part of your healthcare journey. And then improvements in patient education around eye health risk factors. So really knowing and understanding what may come. And then finally, we really think that looking at increasing those interdisciplinary collaborations. So you mentioned the diversity of stakeholders, but we really want to make sure that we're looking at both those who have expertise in eye health and vision and those who do not and may focus on other conditions, OBGYNs, endocrinologists, others who are seeing folks who want to make sure that they keep vision health in mind. And we really think that those stakeholders can create, holistic and comprehensive approaches to these barriers that we're seeing. There's also a lot of policy solutions and levers that we can pull here. We really need to build vision screening into your regular care and maintenance for common health issues for women. We see issues surrounding vision and eye health in certain life stages like pregnancy or menopause. So making sure to keep that in mind will be really important, particularly in the case of TED patients, autoimmune diseases, as we've heard. We want to make sure that women have the ability to engage in those shared decision-making capabilities. So again, fully understanding risk factors, what's going on with their health, to be able to present those issues to their healthcare provider. We really think, again, that expansion of comprehensive access to basic vision screening and care. We've seen this, throughout this conversation that's really critical. We really need to provide sustained funding for the National Institutes of Health and in particular the National Eye Institute over the coming years so that they can invest in this type of research so that we can know more. I mentioned sort of those life stages. I think ensuring that these women at different stages of life are included in the research, whether that's through pregnancy or menopause, all of those issues are really critical because if we don't have those populations included in research, we just won't know more information about them. And I think overall, just really looking at the disparities that we're seeing in terms of care and health and really focusing the research in those areas will really help us go a long way.
Excellent. Yeah, that's there's a lot that can be done. So you just gave us all a great list there. So hopefully we can all go back and watch the video and run through that again and pick out several of those actions that we can do in all of our work. Well, thanks for sharing that breadth of approach that SWHR has undertaken to address the issue of vision health across the lifespan from the perspective of threat blindness. We really appreciate you adopting vision as one of your key priority areas and are happy to continue work with you to advance that. And the information on the burden of disease and role of vision health in the key stages of a woman's life, the need for further research, the intersection of social constructs, and all of these areas, it shows that really we need that focused approach for women across that lifespan. So I know that you mentioned several items that the SWHR created, and the links to some of those items have been included in the chat box. So hopefully our audience is taking advantage of those, as well as other resources to support integration of women's vision health into your overall women's health efforts. So with that, Katie, any final thoughts to share?
Kira, I think you covered it. I do think the biggest message is that really eye health really should be a broader part of this conversation surrounding health holistically. And again, that role of women as both patients and caregivers really does need to be built into these conversations.
That's right. It takes a village. Thank you, Katie. And with that, I will turn it back over to Jim. Thank you for having us, Jim.
Thank you, Kira, and thank you, Catherine. And again, I think that the fact that we had this conversation shows how all of our organizations are working together and we're working on our full circuits to educate about vision care and research. In that regard, I wanted to conclude today's briefing, thanking you all for participating. AEVR wishes to thank our speakers and co-sponsors for their engagement in this important education. I also thank Arvo and Laura Lanford for her streaming support. So note that AEVR's website at www.eyeresearch.org includes a video library of the 10 virtual global congressional briefings that have been held since the pandemic began on topics such as glaucoma, dry eye, AMD, keratoconus, myopia, and of course, thyroid eye disease. You can view those on our website, and you can also read written summaries of those. And of course, we encourage you to spread the message, get folks looking at these. These briefings will be very applicable for the next year or two. Unfortunately, research moves slowly, as does translation of research. So many of these videos will remain very contemporary, at least for the next year or two. Again, we thank you for your time today and have a great rest of the afternoon. Thank you.